My name is Giancarlo Agnelli. I work at the University of Perugia in Italy in the Department of Internal and Cardiovascular Medicine and Stroke Unit. And we are here for EHJ today to discuss the new guidelines of pulmonary embolism that were presented today here in Barcelona at the ESC meeting. And I have the pleasure to have Professor Stavros Konstantinidis from Mainz with me and Irene Lang from Vienna. So, may I start with you, Stavros? What's the new observation in the guideline?
Thank you, Giancarlo. Yes, indeed, we have several new aspects in the new guidelines compared to 2008. We have, in diagnosis of PE, the introduction of simplified clinical prediction rules. We have age-adjusted D-dimer levels, but particularly in the fields of risk stratification and treatment of PE, we have important new evidence and important new recommendations which concern risk stratification, further distinction between intermediate high and intermediate low risk. We have anticoagulation treatment of PE, including now the use of new oral anticoagulants. We have reperfusion treatment for some cases of intermediate risk PE. And we have, of course, updated recommendations on the duration of anticoagulation after PE for secondary prevention.
And Irene, what's your impression? What's your general feeling about what is new?
Thank you. I think what is really new is to talk about the pulmonary circulation as a circulation that needs to be revascularized. And this term of pulmonary revascularization has been used several times. More practical, there's chapters on important conditions that are thought to follow pulmonary embolism, which is chronic thromboembolic pulmonary hypertension, and complete update on that is given. And important subsets like pregnancy and pulmonary embolism and cancer and pulmonary embolism are provided.
Yes, Stavros, the guidelines were presented this morning for the first time to the public. They were also published in the pocket version, and this very nice booklet was distributed this morning to the Congress participants. So could you expand a little bit about the risk stratification and the new antithrombotic treatment?
So in risk stratification, we had a major advancement of the previous table, risk strata table that we had, because until now we had said we have high risk PE, the patients who are in shock, and this of course does not change. We had intermediate risk PE based entirely on right ventricular dysfunction on echo or CT or some biomarkers. We had not specified this further. And we had low risk PE where none of the above was present. Now we have elaborated a little bit on intermediate risk PE because we have substantial new evidence since 2008. And now we distinguish actually or we first use the clinical severity of pulmonary embolism as the criterion, as the first criterion to determine intermediate risk. We recommend using a standardized score like the Pulmonary Embolism Severity Index or the simplified version, the PESI or the SPESI. And then if the patient, by means of this index, fulfills the criteria of intermediate risk, then we distinguish further between intermediate high, those patients that satisfy both the criterion of RV dysfunction on echo or CT plus biomarker, and intermediate low, in which patients satisfy only one of these two criteria. So it is more elaborate, it's a little bit more complex, but we believe now it is closer to the truth and it is better for the treatment of these patients.
You said sophisticated this morning. You really believe it's more sophisticated or it's more clinically useful?
I think it is a little bit more complex, so it is not as easy as the nice table with the green and yellow and red that we had in the previous guidelines, but it is also more useful because we don't just separate those classes from each other, but now we have also recommendation on how to treat each risk stratum. So I believe this is the advancement. We don't just have the epidemiological data, we also have trial data that support this separation and also what to do with it.
So before we go to treatment, any special new information about some special population?
Well, I think guidelines are as good as they cover the entire spectrum, and on that note I'd like to highlight there's a separate chapter on chronic thromboembolic pulmonary hypertension, which is not so rare in an increasingly comorbid population. And one of the highlights is that there's actually surgery to offer to these patients. There is medical treatment. A new drug has been labeled to be used in the condition, riociguat, in the inoperable cases. And there's also the balloon pulmonary angioplasty, which will be a highlight, I think, very soon. Also, formal recommendations are given for pregnancy. The first time, there's a very nice table highlighting that pregnancy is an important condition with PE manifesting just following the same rules as in any other patient.
And Stavros, for the first time, the new agents are in.
Yes.
So could you summarize the new used?
I think this is really, of course, something that many of the Congress attendees were expecting to see what we recommend on this. So the task force evaluated the information and then came to the conclusion that as an alternative to the standard treatment, the new oral anticoagulants, rivaroxaban, apixaban, dabigatran, are recommended in the acute treatment of PE, which is a class 1B for each one of these drugs. We have two strategies. One is single oral drug therapy with either rivaroxaban or apixaban, and we have the drug after the initial parenteral treatment, which is dabigatran, and also edoxaban, which is not approved yet. And so these drugs are now recommended for use in PE as an alternative to standard regimen, and physicians now have a choice of 2 strategies and 4 new drugs to choose from, which makes it more complicated but also much more interesting and many more options to treat their patients. And we also have, of course, the introduction of these drugs into the long term, into the extended treatment after PE, the secondary prophylaxis. And here we also say that the 3 of these drugs that have been tested in this situation, rivaroxaban, dabigatran, apixaban, should be considered as an alternative to the standard VKA approach.
So before we close, I would like to hear about your, let's say, take-home messages, and I would like to start with you, Irene. What would you think are the take-home message for this guideline?
The take-home message is to continue the structured approach to patients, to highlight risk stratification, highlight the level of evidence for the individual subsets of anticoagulation, and to widen the spectrum to think beyond pulmonary embolism.
And you, Stavros, take-home messages?
Take-home message is that risk stratification of PE is a critical issue. It has direct therapeutic implications, and physicians now have a very nice choice of new drugs to treat their patients, and they should adapt all this information and implement it in clinical practice now.
So thank you very much. Before I close this session, I would like to recall you that the booklet about this new guideline was actually presented today, and please don't forget to read the guidelines in the full publication. There are a few pages, but the reading is quite interesting. So thank you very much for your attention. Thank you very much for your participation. Thank you.